Bismillah. Yes. Last time we discussed the non-infectious hepatitis, and today we are going to cover two topics: the alcoholic liver disease and non-alcoholic metabolic liver disease. Abnormal metabolism of copper, iron, fats. It may induce particular type of liver damage, and all alcohol is one of the major leading cause. So this whole discussion will be presented in two uh, sessions. The first session will cover these alcoholic liver disease, and in the second section, we will be discussing these metabolic disorders. You know, alcoholic alcohol is well known to cause uh, liver chronic liver disease. It is the eighth higher risk factors for death. Alcoholic liver disease death, they are quite common, as it leads to in the especially in the Western developed countries and in the countries where the consumption of alcohol is quite much common. Although in Pakistan we usually don't see so much cases of the alcoholic liver disease. Still, in certain minority of the populations, these alcoholic liver disease may become a very important issue. Overall, it is the leading cause of liver disease in the Western countries. Uh, Different patterns of liver hepatocyte injury may be seen, either resulting in the accumulation of fat within the hepatocyte called as steatosis, or there may be some sort of inflammation resulting in hepatitis, ultimately progressive fibrosis, and some ischemia of, affecting the liver sinusoids. So it may appear in any of these forms, like hepatocellular steatosis, accumulation of fat within the hepatocytes, alcoholic hepatitis, inflammation of the liver parenchyma and portal tract, secondary to excessive use or an abuse of the alcohol and prolonged use of alcohol. And lastly, but not least, is the steatofibrosis, accumulation of fat and may be leading to inflammation, but it may directly lead to fibrosis as well. So inflammation in the absence of, fibrosis in the absence of inflammation may or may not be there inflammation, but fibrosis may be there. Uh, Possibly inflammation starts, fibrosis starts directly, or it may be the end result of, chronic inflammation, as most of the chronic inflammation, they are characterized by the fibrosis. So if you see a normal liver is very much when alcohol is exposed to this liver, initially it results in steatosis associated with fatty change and minimal fibrosis of the hepatocyte surrounding the hepatocyte, which are present in close vicinity to the vein, yani in the the central region of the hepatic lobule, hepatic zone. So minimal fibrosis in the form of perivenular fibrosis or chicken one fibrosis and fatty change. These are the two important feature. If only steatosis is there, this is not the steatosis or steatofibrosis. In the steatofibrosis, we have abundant fibrosis, not that minimal fibrosis. So exposure of the alcohol, it leads to steatosis and perivenular fibrosis in the liver. Abstinence, but as you know, this is a reversible condition. So the abstinence from alcohol may revert the liver back into a normal situation. When there is severe exposure, either in the liver which has already been steatosed and having minimal fibrosis, or in the normal liver, may directly undergo the process of hepatitis associated with necrosis of the hepatocyte, inflammation, Characteristic formation of Mallory dunk bodies, which are eosinophilic bodies found in the hepatocyte of these drunken individuals, plus minus this fatty change. So inflammation and necrosis is much more common in hepatitis. Again, these all these changes, fatty change, Mallory bodies, inflammation, and necrosis of the hepatocyte, they are reversible up to a limit. Even the severe exposure of alcohol to liver, it may induce all these changes, but it again, these changes are still reversible, and the abstinence may result in the liver becomes normal once again. But either due to continued exposure or due to the repeated attacks, similarly, steatosis liver, which has already developed steatosis, may develop ultimately is hepatitis, is all called as steatohepatitis, alcoholic steatohepatitis, or ASH. And then repeated attacks of this severe exposure or continued exposure may ultimately result in the cirrhosis, fibrosis, forming of hyperplastic nodule, chronic liver disease, increased risk of developing hepatocellular carcinoma, and all the complication of chronic liver disease. Most of the time, we have a dose-dependent reaction, dose-dependent toxicity. Uh, there is short-term ingestion, let's say, of alcohol for a couple of days or for several days generally produce mild reversible hepatic steatosis. But if the intake it extends, it progresses, it becomes prolonged, it generates significant risk for severe hepatic injury. And if there is the dose is increased and the duration is also increased, so this is usually consistent with severe injury. However, not all the alcoholic persons, they develop chronic liver disease. Only 10 to 15% of these alcoholics, they do develop cirrhosis. Rest of the people do not develop cirrhosis. This is one of the reasons that some other factors may thought to be involved in the pathogenesis of alcoholic liver disease. If alcohol is the exclusively the only factor, then all the alcoholics should have some sort of chronic liver disease. But as they do not develop, all of them do not develop. Only 10 to 15% of the person who are alcoholic, they develop alcoholic steatohepatitis, and similarly, uh, subsequently they do develop chronic hepatitis, chronic liver disease, cirrhosis, and increases of hepatocellular carcinoma. So, what are the predictors basically that are associated with the development of cirrhosis in an alcoholic patient? So, we have three. We have included these through three important factors: the gender, the ethnic and genetic differences, and comorbid conditions. So these three are situations which may be let's say associated with increased risk of developing alcoholic steatohepatitis and ultimately chronic liver disease. Amongst the gender, female are said to be more prone to develop alcoholic steatohepatitis and chronic liver disease rather than the males. Similarly, European and American peoples ethnically, they are more prone to develop rather than the Asian individuals. Some genetic differences, some dietary factors, and some drinking, habits, they may have influence on the development of alcoholic steatohepatitis due to excessive alcohol injection and other comorbid conditions. If they are present or not, they usually, act in synergy, and they will speed up the process of chronic steatohepatitis. So as you see, there are three different patterns of steatohepatitis or alcoholic liver disease, which we can see in the pathology of the liver. They are hepatocellular steatosis, steatohepatitis, and fibrosis. So steatosis usually results from alcoholic dehydrogenase, the enzyme which is responsible for uh, detoxification of not only of the alcohol but also some other aldehydes. So there will be increase ALDH, and this increase LDH, uh, you know, it may be associated with, it is usually increased at the cost of other enzymes. So shunting of normal substrates away from the catabolism and toward liver biosynthesis, it usually results, and it more and more lipid they are being synthesized and metabolized within the liver, so resulting in steatosis. Then there may be some impaired assembly and secretion of the lipoprotein. They are not being secreted properly from the hepatocyte. So they are accumulating within the liver, resulting in the steatosis. And last but not least, alcohol is not only causing some damage to the hepatocyte, injuring to the hepatocyte, and their capability of, uh, you know, metabolizing these fat molecules is to comprehend. On the other hand, it is also a very important factor for the mobilization of free fatty acids from the peripheral stores. So fat, it usually mobilizes itself from the fat depots, especially in the abdominal fat, peritoneal fat, and then this fat is moved into the liver. So there will be increased fatty acid entry as well. So increased entry and defective metabolism leads to accumulation of fat within the uh, cells of the liver, which have suffered from severe alcoholism. Uh, Alcoholic hepatitis or inflammation, it may result from free radical formations due to lipid peroxidation uh, caused by alcoholic dehydrogenase. Similarly, cytochrome P450 enzyme system is activated, and it results in the formation of increased reactive oxygen species. So free radicals are formed, and they are associated with causing injury to the hepatocyte and eliciting an inflammatory response. Repeated bouts or repeated attacks would definitely be associated with a chronic inflammation. This induction of P450 oxidase system is a very important phenomena, as it causes enhanced conversion of drugs or chemicals to toxic metabolites. So this is, this is the place, this is the point where we usually need increased amount of drugs being given to these patients, which show some sort of enzyme induction in their, either in the liver function test or within the liver cell in their form of increased hyperplasia of the smooth endoplasmic reticulum and more formation of 450 of P450 oxidase system. And that usually, so if we need, let's say, if a person has shown this enzyme induction and he or she is supposed to have a surgery, so we need to give him her larger doses of anesthetic drugs as compared to a normal person. Similarly, because the drug will be soon metabolized, early metabolized within the liver due to enzyme induction. Then one may have release of bacteria and toxin from the gut in the liver. There may be some perfusion issues of the hepatic sinusoids. So, a number of factors, multiple factors may be involved in eliciting the inflammatory response due to alcoholism. What we usually see in the alcoholic steatohepatitis, the term steatohepatitis is usually used, referred to as the accumulation of fat within the hepatocyte as well as presence of the inflammatory infiltrate, either in the lobules, more predominantly, or when it has involved, the portal tracts as well. So cellular swelling and necrosis and ultimately inflammation. Initially, the inflammatory response is acute inflammatory reaction. The cells are neutrophils. Gradually, they are replaced by the macrophages and finally by the lymphocyte in the basic phases of the chronic inflammation. And that will induce considerable amount of fibrosis in the hepatic parenchyma. A very characteristic appearance of an eosinophilic dark pink colored body, which is the I'll show you later okay, how it appears and why it is formed. It is an amorphous eosinophilic material usually deposited in the ballooned hepatocyte having ballooning degeneration, and this body is called as Mallory Dunk bodies. So Mallory Dunk bodies, they are usually characteristic of these alcoholic steatohepatitis. Neutrophilic reaction will be there, plus minus some mononuclear cells, and alcoholic steatofibrosis ultimately ensues. And in the alcoholic steatofibrosis, the fibrosis initially starts around around the cells which are present in the close vicinity to central vein. So zone 3 cells are more vulnerable to develop these fibrosis. Initially, the fibrous tissue is accumulating, a thin fibrous tissue is accumulating surrounding these individual hepatocytes. So a chicken wire pattern of fibrosis or perisinusoidal scars are usually present. So these fibers are accumulate within the space of this, and then you know, in a chicken wire fence pattern that we have seen a bird cage. So the bird cage, you know, the cage in which the birds are usually placed, especially if you see, you might have seen on the chicken shops, the chicken are placed, and they are placed in a cage, and the cage is having a fence which is made up of light, I mean, not that thick steel rods, similar, and they are of irregular shape, usually hexagonal. Similarly, we are having these chicken wire pattern of fibrosis, thin amount of fibrous tissue if it is surrounding the hepatocyte, which is roughly hexagonal or polygonal. So it gives a chicken wire fence pattern of fibrosis. And eventually, this fibrosis, it links to the portal tracts, and then in the forming a central portal fibrous septa or bridging fibrosis, or ultimately forming micronodular cirrhosis, small nodules cirrhosis forming composed of small nodules. Micronodular cirrhosis are also called as Linic cirrhosis. So if you see in this photomicrograph, what we see is, okay, we are having, you can see this is the central vein. Then we are having around the central vein. This is not an H&E stain, right? It is Mason trichrome stain. Trichrome basically composed of three colors. So you can see blue, pink, and purple color. Purple is for the nuclear stain. Blue color is usually for fibrous tissue. So where there is fibrosis, there is blue color. So it is perivenular fibrosis. And if you see, it is, surrounding the whole hepatocyte from all of its aspect. All aspect of the hepatocyte, they are covered, giving a chicken wire type of fibrosis. Chicken wire type of fibrosis. We starts in the cells surrounding these uh, central vein, and then this fibrosis, it extends from here to the portal tract. And another thing which is quite prominent, and you can see the accumulation of these fat vacuoles within the hepatocyte. So what we are basically looking at is steatofibrosis. Obviously, inflammation is not that prominent, but what we see is basically steatofibrosis, steatosis and fibrosis. Fibrosis in a chicken wire pattern. Similarly, if you, like if we see here, uh, hepatocyte, some cells are showing signs of degeneration, like this one, like this cell, like this cells. Yeah, nucleus is up around about to disappear. Then we have these foci of lobulitis. Not only the mononuclear cells, but these polymorph nuclear cells, neutrophils, they are also present. So neutrophils are present, and in the lobules, causing degeneration, inflammation, and if you see clumped, you can see, okay, we are having these you know, cytokeratin molecules, especially, cytokeratin 8 and 18, which is now clumped intermediate filaments. They are proteins which are clumped. Are usually distributed in a regular fashion in the in close association with the cytoplasmic membrane. But due to injury, they are released from the membrane. They accumulate within the cell, and they become they appear like a pink amorphous uh, body, clumped proteins, and they are called as Maillard bodies. So Maillard bodies is quite characteristic of the alcoholic hepatitis, and as well as these, if you can see, these foci of steatosis as well. So steatosis is there, Maillard body is there, inflammation is there. All are favoring the feature of what we usually call as steatohepatitis. Again, the same photograph, but is a bit enlarged and zoomed, and you can clearly see the Maillard bodies with surrounding fibrosis surrounding these individual hepatocyte, degenerating hepatocytes in a chicken wire pattern. And these are the Maillard bodies. These are Maillard bodies. Okay. Ultimately, they develop, cirrhosis, a micronodular form of cirrhosis. Grossly, it appears something like this: small nodules arising from the surface of the liver. So clinically, patient may have mild hepatomegaly, mild enlargement of the liver initially, and when there's cirrhosis, when there is steatosis or steatohepatitis. But when there is cirrhosis, the overall size of the liver, it becomes reduced. But in the earlier cases, there may be mild hepatomegaly, and there may be some elevated serum bilirubin and alkaline phosphatase level. Why alkaline phosphatase level? Because liver cells are degenerated, and the fibrosis is typically present around the space of this, and the membrane is usually injured. And when these enzymes are usually sequestered within the close proximity to the cytoplasmic membrane, that is why the alkaline phosphatase level are usually raised. And obviously, not only alkaline phosphatase, but the transaminases level is usually high as well in cases of the steatohepatitis. But this is a bit, in the classical cases, we usually see increase in the AST level more than the ALT. What is, if you remember, what was happening in the viral hepatitis was ALT level was more than AST. So ALT to AST ratio was 2:1 in those cases, while here AST level is more than the ALT. So aspartate transaminase to alanine transaminase ratio will become 2:1. And ultimately, acute cholestasis may be there, resulting in some stasis of the bile, as they are resembling large bile duct obstruction. This is more discussed in the lecture, which will be, or discussion, sort of discussion, which will be on the topic of these cholestasis. Hopefully, will be followed soon, inshallah. So this is just the photograph to show you, okay, how where the basically the target of this fibrosis is. So if the fibrosis is something like this, it will definitely give a chicken wire pattern of fibrosis. Burning cells, cell membrane, where the alkaline phosphatase is sequestered, and this is undergoing the process of fibrosis. So it is giving a chicken wire fibrosis with accumulation of fat within the hepatocytes, uh, may or may not be associated with inflammation. So this is a typical characteristic feature of alcoholic steatosis, alcoholic steatohepatitis, or alcoholic steatofibrosis, ultimately leading to micronodular cirrhosis. Um, Abstainers, they usually have a very good I mean, as we discussed earlier, that uh, the alcoholic hepatitis or alcoholic steatohepatitis, they are usually having a dose dependent interaction. So if the dose is reduced, if the alcohol is abstained, most of the findings, they usually regress, and the liver, it turns out to be normal before the fibrosis, if it starts developing. Minimal fibrosis may be, encountered, and even then, this may be stopped or arrested. But if the process continues, if the ingestion of the alcohol continues, if there is prolonged and heavy exposure to alcohol, it would result in, uh, like 90, the survival rate, it reduces from 90% to 50 to 60%. In the end stage alcoholic, death may be ensured, and the causes of death may be multiple, like which are usually associated with the chronic liver disease, complication of the chronic liver disease, that we have discussed in this section of signs symptoms of chronic liver failure. So there may be hepatic encephalopathy leading to coma. There may be massive gastrointestinal hemorrhage from the bleed esophageal varices, from intercurrent infection, hepatorenal syndrome, and last but not least is the hepatocellular carcinoma. So if you see, in cases chronic alcohol abuse, a normal liver is transformed into steatosis. This will be seen in 90 to 95% of the person who are chronic alcohol abuse. But from steatosis to fibrosis, it only develops in 20 to 40% of the individual. Similarly, fibrosis extending into or progressing into micronodular cirrhosis in only 80 to 20% of those who have developed fibrosis. And lastly, those who have developed cirrhosis, out of these 3 to 10% of the individuals will develop hepatocellular carcinoma. So if we see, out of 90%, only 20% will develop fibrosis. Of these 20%, 8 to 20% will develop cirrhosis. And finally, of these 8 to 20%, only 3 to 10% will develop it as hepatocellular carcinoma. So roughly 10% of the pupils who are chronic alcohol abusive will develop cirrhosis, and out of these only 3 to 10%, 1 or 2% probably will develop hepatocellular carcinoma. And the factors that affecting uh, maybe they are female genotype, obesity, certain dietary factors, single nucleotide polymorphism, drinking pattern, smoking, comorbidity, like the person is also having viral hepatitis, hemochromatosis, or HIV infection, or something like this. So with this, we have finished the pathology of alcoholic liver disease. We discussed some sort of actions or deleterious effects of alcoholism on liver, and discussed their pathology and pathogenesis briefly. And we have seen some morphology of different patterns of the liver injury, which is produced by the in the severe alcoholism. I hope that would work in a positive way to understand, and in understanding the pathogenesis and morphology of the liver due to chronic alcoholism. Inshallah, soon we will be discussing these non-alcoholic steatohepatitis and other metabolic disease, hopefully. Thank you very much. Have a good day.